Good morning, everyone. We're just setting up so that we can begin to go live on Facebook, and then we will begin momentarily. All right. All right. Regina, can you confirm that on the sickle cell page, we can see the live stream? All right, welcome everyone to today's session of Sickle Smart Summer. This is actually the July session. I want to make sure that, can everyone see me? It's the thumbs up, perfect. This is the July session of Sickle Smart Summer. We're very excited. It's the third month, and each month has been increasingly more successful. We are actually hoping to expand this program throughout the rest of the year and into 2021. It has been just that successful. If you have missed previous sessions, we invite you to go to our website at www.SickleSMN.org. Again, that's SickleSMN.org. You can not only sign up for future sessions, but you can access the recordings from previous sessions as well. For those in the sickle cell community whom much of this information is geared towards, as well as providers, we just want to start out by reminding you that it is summertime. Drink water. It's going to be very hot. Yesterday was very hot. I believe the heat index was about 108. For those of us in Minnesota, that is extra hot. But though we do not wish for snow right now. But drink up lots of fluids. We really encourage you to stay hydrated during these times. We also remind you to mask up. We know that this is a new normal. No one is going to care for your health as much as you will, first and foremost. So protect yourself. Mask up. If you need masks, please contact us. You can always reach us at SickleSellMN@gmail, or you can contact us through our website. Lastly, we don't want you to suffer in silence. If you are having pain, or if you feel that your body is not in the condition that it needs to be in to continue to do well, please don't suffer in silence. Please reach out to your provider. Please identify ways that you can connect with a healthcare professional, and look for ways to take advantage of telehealth. We look to do a session down the road on telehealth to invite you all to engage in this wonderful process that it basically brings healthcare into your home without them coming through your doors. So it is a wonderful alternative, and we do hope that the community is embracing that. Today's going to be a wonderful session. We are going to start with our first presenter, who is Dr. Rai. She hails from the St. Jude Medical Center, and she will talk about acute medical complications across the lifespan. And then we're going to hear from Yvonne Carroll, who is a nurse practitioner also at St. Jude, who will speak more in depth about clinical trials and some of the barriers to participation in clinical trials. And then we'll wrap up with Dr. Angie Smith from the University of Minnesota, who will talk about curative therapies in sickle cell disease. So we're very excited for the program that is ahead. We thank all of our sponsors who have undoubtedly helped to make this happen. The Links Foundation, Storm, Yukon Health, Children's Minnesota, Be the Match, Bluebird Bio, mHealth, Memorial Blood Centers, GBT, Z100. We are just blessed to have some wonderful sponsors, and so we thank you for that. And without further ado, we're going to turn this over to Dr. Rye. Dr. Rye, go right ahead.
Good morning, everyone. Can you hear me? Okay. So I'll thank the organizers for inviting me to present at this wonderful platform. My name is Parul Rai. I'm a junior faculty at St. Jude, and my area of interest, clinical and research interests in sickle cell disease. So today I'll just be talking about the medical complications of sickle cell disease across the lifespan. I have no disclosures. So basically, we'll just discuss the etiopathogenesis, the symptomatology, management and prevention of some complications. And these are the complications I'm going to discuss about. All right, to begin with, as we can see over here, this is a graph that shows the age at death of individuals with sickle cell disease reported to the CDC database in 1979, 2006, and 2014. And as we can see, that there's a shift in the age of death to older age. So this is because of implementation of interventions like newborn screening, vaccination, penicillin prophylaxis, and transcranial Doppler screening, because of which we've improved childhood survival to around 96 to 98%. However, the median age of death in adults hasn't improved much since the Cooperative Sickle Cell Disease study data that was published in 1994, where the median age of death is still in the mid-40s. So the median survival for adults with sickle cell disease is almost 20 years shorter than for African Americans living in the US. So as we can see, sickle cell disease is a multi-system disease with organ injury that's ongoing, because of which the complications kind of accumulate with age. While there's some complications that are throughout, like for example, pain crises that are present in all ages, at all stages, but the frequency and severity of these complications get worse as you grow older, and then new complications develop over time. So to begin with, I'll talk about fevers, which is an emergency in sickle cell disease. So infection is the leading cause of death worldwide, and this increased susceptibility to bacterial infections in sickle cell is because of functional asplenia. So splenic dysfunction that occurs because of trapping of the sickle cells in the red pulp of the spleen and the ischemic injury that happens, and this persistently over time results in replacement of the splenic tissue with fibrotic tissue. So this begins pretty early in life, almost around 6 months of age. And by 2 years of age, almost 90% of infants with SS would have lost their splenic function. And by 5 years, most of them. So spleen, besides filtering the bacteria and the pathogens and the damaged red blood cells, also produces opsonins like complements, antibodies that kind of attach to the bacteria, bind to the bacteria, and trigger phagocytosis. So because of loss of this, there is overall immune dysfunction and increase, and there's a propensity for overwhelming infections with encapsulated organisms like streptococcal, pneumococcal infections, Haemophilus, and meningococcal infections. So the penicillin prophylaxis study was done to determine whether daily administration of penicillin will reduce the rate of infections in children. So this study showed that when we did this, there was actually an 84% reduction in incidence of infection in patients who were on penicillin compared to the placebo arm. And this study was actually terminated pretty early because of the success. So we do penicillin prophylaxis starting as early as 2 months of age. We start off with 125 milligrams twice a day, and then this is increased to 250 milligrams around 3 years of age. And we usually stop this by around 5 years of age based on the data from the PROPS2 study, which was another subsequent study that was done to address the appropriate length of this penicillin prophylaxis and found that there was no additional benefit of continuing it beyond 5 years of age. That could be because the incidence of infections kind of decrease in an older age, and plus there was some concern or trend towards carriage or colonization with multi-drug resistant bacteria. So that's why we kind of stop beyond 5 years of age unless there is a surgical splenectomy that was done or there was a history of pneumococcal sepsis until the patients are updated on the immunizations. So besides pneumococcal immunizations, we also give meningococcal immunizations. And as if when the surgical splenectomy is done, besides completing the immunization, we also do not stop the penicillin in this patient population. So how do we manage fevers? So if there's a fever of more than 100.9, we advise the patients to come to the ER immediately, or if it's more than 100.4 and persists for greater than 1 hour. The basic labs, as we know, that are done are CBC, cultures, urine and blood cultures, chest x-ray if there are any respiratory symptoms. The goal is to give antibiotics within 1 hour of arrival to the ER. So we start off with giving ceftriaxone and usually observe the patients for around 3 hours after that. So when we discharge the patients, either it can be on high dose amoxicillin for 48 hours till the blood cultures come back negative, or we give a second dose of IV antibiotic and we call the patients in the next day. If there is any concern, as in the patient has a toxic appearance, hemodynamic instability, really high fevers, white blood cell count being really high around 30,000 plus, or there's a history of pneumococcal sepsis, or if the patients are really young, in this patient population, we usually admit them and we consider adding vancomycin. So the other complication that is usually seen is these acute anemic events that can be from splenic sequestration, aplastic crises, hepatic sequestration, or hyperhemolytic crises. I will discuss the first 3 of these complications. So splenic sequestration is basically the trapping of the sickle red blood cells within the spleen. So it's a vaso-occlusion that's happening within the spleen. The peak incidence is around 6 months to 3 years of age. And that's because, as I said before, that by around 2 years, there's functional asplenia, and by 5 years, there's autosplenectomy and loss of splenic function. So the incidence of acute splenic sequestration actually goes down as you grow older, unless the splenic function is preserved, like in patients with hemoglobin SC, or if patients are on hydroxyurea and the splenic function is preserved, you can have this complication even later in life in those patients. So they usually present with pallor, tachycardia, irritability, lethargy. So there's a drop in hemoglobin by almost 2 grams from the baseline. And that's accompanied by rapidly enlarging spleen, which is very tender. There can be also a drop in the platelet count by around 50% and plus minus reticulocytosis. So these patients present with severe anemia, and there is a potential for going to hypovolemic shock. So that's why they should be managed pretty emergently. So when they're hemodynamically unstable, while you're trying to arrange for the blood, you can start with fluids, give normal saline boluses at that time. The goal is to transfuse them to around 8 grams, but you have to give it in aliquots because of splenic release phenomenon. That means when you give the blood, the red blood cells that are trapped in the spleen actually come out. So there is an increase in the hemoglobin higher than expected. So we should give blood in smaller aliquots and make sure that it's type and cross-matched for the minor antigens. So there's a 50% chance of recurrence of a splenic sequestration within 6 months. And usually after the second incidence, a surgical splenectomy is planned when the patient is stable. If the patients are really young and you do not want to do a surgical splenectomy at that young age, you can consider doing monthly transfusions to delay the splenectomy. Some places can also consider partial splenectomy, even though the benefit of partial splenectomy has not been shown. So besides splenic sequestration, there are other manifestations that can occur because of moderate trapping of the sickle cells. So this can be like just splenomegaly, in which you don't really have that dramatic drop in the hemoglobin, or other cytopenias like thrombocytopenia. We don't really see that. And this is usually seen in patients who have slightly higher hemoglobin F levels, so their splenic function is preserved for longer, or they have co-inheritance of alpha thalassemia and not so much hemolysis. The other thing is hypersplenism that can occur, which usually follows an acute splenic sequestration episode, and in which the spleen after the episode doesn't go back to baseline and it's still enlarged. So usually hypersplenism is associated with some with lower hemoglobin, thrombocytopenia levels. And if it is sustained, it can result in bone marrow hyperplasia, and subsequent growth impairment can also be seen over time. So in patients with hemoglobin SC, the functional asplenia occurs at a later age and to a lesser extent. So it's usually like in about 42% of patients by around 12 years of age, they have functional asplenia. So in patients with hemoglobin SC, you can actually have these episodes of splenic sequestration occurring at a older age as well. So it's always important that in all the exams that we do, we should document the spleen size. So we know what is the baseline spleen size, and patient education regarding, or parent education, in fact, regarding what the baseline hemoglobin level is and how to palpate and measure the spleen is very important, because it's usually on the parent's exam that they figure out that something is wrong and they can get the child to medical care immediately. And after splenectomy, these patients need to be on prophylactic antibiotics with penicillin. So the other acute anemic event that we usually see is that is triggered by parvovirus infection, and it's called aplastic crises. So there is transient red cell aplasia that can occur. Mostly it occurs because of parvo infections, around 70% of the cases, but can also be triggered by other viral infections like adenovirus or EBV infections. So this occurs because there is direct cytotoxicity to the erythroid precursors, and this in combination with the short lifespan of the sickle red blood cells results in this transient red cell aplasia. So usually patients can present with some non-specific viral illness, so they can have fevers. The characteristic slapped red cheek kind of appearance may be absent. There is again a dramatic drop in the hemoglobin, which can be associated with mild neutropenia and thrombocytopenia. But the most characteristic feature is that you have a precipitous drop in the reticulocyte count. So you have reticulocytopenia, which is different from the splenic sequestration episodes in which you can have reticulocytosis. So when both these patients present with a drop in hemoglobin, the thing to look out for is at the retic count. If the reticulocyte count is very low, then you should suspect this being aplastic crises. Then the erythroid aplasia kind of peaks at around 8 to 10 days of 8 to 10 days, and the positive serology, so an IgM will be positive, which kind of supports that this is the cause. In some patients, actually, this parvo infection, besides causing the aplastic crises, can also trigger a splenic sequestration episode. So here you have like concomitant splenic sequestration and aplastic crises that's happening. This usually is seen in older children with the splenic function that is preserved. So in SC patients or SS patients who are on hydroxyurea, this can occur in them. And usually it's characterized by splenomegaly, anemia, but with the splenomegaly, you have reticulocytopenia. So it's like a combination of symptoms in which you're getting the splenomegaly because of the splenic sequestration, but there's reticulocytopenia due to the aplastic crises. These patients can also develop acute chest and other multi-system dysfunction. So the take-home message is, if in patients, older patients who are having a parvo infection and have the splenic function preserved, do monitor for those patients carefully because they are at risk of having splenic sequestration as well. The epidemiology is unclear, and besides close monitoring, supportive therapy with transfusions as required should be done. So management of aplastic crises, just monitor the CBCs and retics closely until recovery, hold hydroxyurea because that can worsen the reticulocytopenia, and transfusions as required. So the next complication I'm going to talk about is hepatic sequestration. So there is an umbrella of symptoms that you see with the sickle hepatopathy, which is basically intrahepatic sickling. So the sickling is now happening in the liver, so the intrahepatic sickling that occurs, resulting in ischemia, sequestration, and cholestasis. So the spectrum of symptoms that you can see can range from an acute hepatic crisis, acute hepatic sequestration, and intrahepatic cholestasis. So hepatic sequestration, the one that I've highlighted over here, is the one that usually presents with anemia, hepatomegaly. You have hyperbilirubinemia, so the increase in bilirubin is seen, compared to the other manifestation in which you also see like the hepatic crises and intrahepatic cholestasis, in which you also see a transaminitis that accompanies the hyperbilirubinemia. To manage the hepatic sequestration, transfusions, preferably exchange transfusions, should be done. All right. Switching gears to the neurological complications that we can see. So the acute neurological events in this patient population include the most common stroke, so which can be ischemic, basically arterial, or hemorrhagic. Hemorrhagic stroke is usually happens in patients around 20 to 30 years of age, and it's mainly subarachnoid hemorrhage. The other event that they can present with is posterior reversible encephalopathy syndrome, so PRES. And they usually present with headaches, seizures, altered mental status, visual disturbances. And this can be triggered by an acute chest syndrome event, or can be post-transplant with cyclosporin use or with hypertension. Then cerebral sinus venous thrombosis is rare, but when presents, can mimic stroke with headache, nausea, vomiting, cranial nerve palsy, and seizures. MRV is the way to diagnose this, and anticoagulation needs to be done to treat it. Headaches is very common in this patient population, chronic headaches. So around 15% of children will have migraines, 30% have recurrent headaches. So based on the symptom and the history of migraine, you don't really have to rush and do imaging in these patients if you're sure this is just migraines or recurrent headache. However, if patients present with an acute headache, you need to consider hemorrhagic stroke because that is how they usually present. And they're usually older age with a prior history of transient ischemic attacks or TIA or stroke. And the headache is usually accompanied by some neurological deficits. Seizures is again pretty common, around 2 to 3 times more common in patients with sickle cell compared to the others. When we are doing EEG, we need to take into consideration to avoid hyperventilation during EEG, because given the high rate of moya, there's an increased risk of ischemic events that can happen if you do hyperventilation. So avoid doing hyperventilation when you're doing the EEG to monitor for the seizures. So the two main complications I'll talk about is stroke and silent cerebral infarcts. So overt stroke means that you're having neurological deficits along with corresponding abnormal MRI findings. This usually occurs because of stenosis. So because of the repeated sickling episodes, there's injury to the endothelium, resulting in endothelial hyperplasia and intraluminal thrombosis, which causes the stenosis. And over time, there can be occlusion and decreased blood supply distal to the occlusion. So without the TCD screening and primary stroke prevention with the blood transfusions, the prevalence of overt stroke was around 11% by 20 years of age and around 20% by 40 years of age. With the introduction of TCD screening and doing prophylactic transfusions in patients with abnormal TCD, we are able to decrease this prevalence to around 1%. Transient ischemic attacks, which means that usually you just have symptoms without any MRI findings, can precede stroke. And if no interventions are done after a first stroke, there's a 50 to 90% chance of recurrence. Silent cerebral infarcts is another injury that is very common in this patient population, and in which you have abnormal MRI findings, but a normal neurological exam. Or you could have some abnormality in the neurological exam, but that is not explained by the location of the brain lesions on the MRI. So, so despite the fact that you don't have any neurological deficits with the silent cerebral infarcts, it is associated with neurocognitive impairment, and there's an increased risk of further CNS complications, meaning individuals who have a pre-existing SCI have a significant risk for getting a new SCI or overt stroke. So the cumulative risk of SCI increases with age. It's around 25%. So 1 in 4 patients would have had it by 6 years of age, around 39% by 18 years of age, and more than 50% in adults. So the SID study showed that it can be regular blood transfusions can substantially reduce the incidence of new stroke, silent infarct recurrence in patients who have normal TCD. But there is a certain patient population that continues to have these complications despite transfusion. So it is not 100% protected. So as we can see over here, there is a bimodal distribution. So this is the smooth hazard ratio of ischemic and hemorrhagic stroke in SS patients by age. And the risk of an infarctive or ischemic stroke is highest by 20 years of age, and it peaks at around 10 years of age. And then there's another peak that happens after 30 years of age. Hemorrhagic stroke risk is highest between 20 to 30 years of age, as we can see over here. So trying to identify the risk factors for stroke and silent cerebral infarct, the predominant thing that you can see over here is low baseline hemoglobin. So anemia at steady state and acute anemic events that can happen dramatically decrease the oxygen content and cause tissue hypoxia, then decrease the oxygen saturation that can be seen with acute chest syndrome events, can also decrease the low oxygen content and tissue hypoxia. So there is basically baseline increased cerebral blood flow that happens to compensate for this. But if it's unable to do this because of an underlying vasculopathy, this combination can result in ischemic events and stroke or silent cerebral infarcts. And when I talk about vasculopathy, I mean like there's stenosis, occlusion, moya, all this is included. So the symptoms will include hemiparesis. So make sure that you know if it's weakness versus pain. A lot of times we get report of there being not able to move an extremity, but it's actually not because of weakness, it's because they're in so much pain they don't move it. So distinguish between the two, so you know whether you should be concerned about stroke or not. There can be some seizures, more focal more than generalized, altered mental status. Headache alone is usually not a symptom, but if there's an acute headache accompanied by some neurological deficits, then you should be concerned for a hemorrhagic stroke. So how do you manage? The immediate assessment by hematology and neurological services should be done. Try to keep the oxygen saturations more than 95% with oxygen therapy, while the preferred thing is we have to do an exchange transfusion. So while you're waiting to get blood, you can do fluids, but judicious use of IV fluids while waiting for getting the blood ready. You should get CBC retic, basic metabolic panel, hemoglobin S quantification, so you know what the hemoglobin S level is at. So preferably an exchange transfusion should be done, but in some cases you cannot get it arranged immediately. So in the meantime, a simple transfusion can be done if the hemoglobin level is below 8.5 and exchange transfusion is not available within 2 hours of presentation. You can start off with a simple transfusion and then follow it with an exchange transfusion to decrease the hemoglobin S level. From an imaging point of view, MRI is usually preferred because it's very sensitive to look for ischemic injury, especially if there is diffusion weighted images that are added. which can tell you whether this ischemic event happened within the last 10 days or not. If this is not available, CT scan can be done, which is usually to make sure that there is no hemorrhage that is happening. In a lot of institutions, they have kind of set up a scan sequence that can, MRI scan sequence that can detect ischemic and hemorrhagic events. So that would be ideal. So MRI is preferred in those cases, but if not available, CT can be done, and then you can follow with the MRI when the patient is stable. But remember not to delay therapy for imaging. If there is a high suspicion of this being stroke, you should start with the therapy, start doing the transfusion, and not delay it just to get imaging. TPA use is kind of not very sure. It's not done in the pediatric population. So usually patients should be above 18 years of age, and they should meet some inclusion criteria, meaning if there's a history of atrial fibrillation or hyperlipidemia, diabetes, in those kind of patients, you can consider TPA. But again, do not delay that. Do not delay a transfusion for this. So over here, we can see if a patient presents, a pediatric patient presents within 72 hours with acute onset of neurological deficits, we can see what the hemoglobin level is at. If it is less than 8.5, then you can do a simple transfusion, then top it up with the exchange transfusion to decrease the S fraction. And if it is more than 8.5, then it's preferred to just do exchange transfusion because of the risk of hyperviscosity complications that can happen. So the advancement in preventing neurological injury was done with the initiation of TCD to determine the stroke risk. So the TCD is more than 200 considered abnormal. So the STOP study was the landmark study that showed that blood transfusions, monthly blood transfusions, can reduce the risk of first-time stroke by around 90%. Subsequent studies show that discontinuation of transfusions resulted in the TCD velocities to revert back to abnormal with an increased rate of silent cerebral infarcts and overt strokes. Hydroxyurea role has also been looked into stroke prevention, and while it's recommended for primary prevention of stroke, especially if patients have had at least 1 year of transfusions with normalization of the TCD velocity and no underlying vasculopathy. Those patients can be, per the switch study, switch to hydroxyurea. Hydroxyurea is not shown to be beneficial as compared to, it's not considered better considered to transfusions for secondary stroke prevention. However, if you cannot do transfusions, hydroxyurea is still better than just observation for secondary stroke prevention. However, in a certain set of patients, you will continue having increased recurrence of stroke and silent cerebral infarcts despite transfusions. And this is because the stenosis or the vasculopathy is, if not prevented by transfusion, it's slowed down, but it's not prevented by transfusions. So as the vasculopathy progresses, you can continue having an increased risk of strokes and infarcts, silent cerebral infarcts, despite transfusions. So as you can see over here, that in patients who have vasculopathy, they do have an increased risk of stroke recurrence versus patients who do not have progressive vasculopathy. And this is same for silent cerebral infarcts, in which presence of vasculopathy will continue to have more SCIs compared to patients who do not have progressive vasculopathy. So TCD screening is effective in identifying kids at risk for stroke. Chronic transfusions prevents most strokes, better for primary prevention, not 100% protected for secondary prevention. But the chronic transfusions do not prevent the vasculopathy or future stenosis, because of which there's a certain section of population which continue to have recurrence of silent infarcts and strokes with this progressive vasculopathy despite transfusions. And hydroxyurea is only proven to be safe for kids with a normal TCD without severe stenosis. So that's why we should start thinking about curative options like transplant and gene therapy for kids who've had stroke, kids who have abnormal TCD, and who have stenosis on MRA. So the next complication is pain. So this is the most common cause for ED visit and admission throughout life. It begins as early as 6 months of age, and then it can affect long bones, joints, virtually everywhere. Lower back is the most common site for pain, but can affect any region. And it can get complicated and can even follow into an acute chest episode. So management of pain is very important because it affects future coping, and individualized, personalized protocol for outpatient and inpatient pain management have been shown to improve quality of life and decrease hospital admission. So this is when they present early in like around 6 months of age as dactylitis. So how do we manage this pain crises? So majority of the pain episodes are managed at home with analgesics and hydration. But when patients do come to the ED, the main goal is to do rapid assessment and administration of pain medication within 1 hour of ED arrival. And then the second is to do frequent assessment every 30 to 60 minutes. Individual pain plans in which you already know which medication works and what dose works are good because they can be used to guide your opioid dosing when they present acutely. NSAIDs for a short course around 5 to 7 days can be given, but avoid if there's any concern for renal injury, as in if there's increasing creatinine or proteinuria, you should try to avoid NSAIDs if possible. ASH guidelines that were published in 2020 did not really offer recommendations as in for or against IV fluids. So the thing is, you want to avoid dehydration because that can worsen sickling. But there is this concern of underlying cardiac dysfunction, especially in adults. So in our institution, we've stopped doing normal saline boluses. We just do maintenance hydration. However, if the patient comes in with like a concern for shock, then you can do more aggressive hydration, but try not to do that because they can decompensate, especially if they have underlying cardiac dysfunction. Again, recommendations for basal or opioid dosing were not done. So if pain is not controlled with PRN or scheduled intermittent dosing, do not delay, and you can start patient-controlled analgesia with a PCA, so which will give you a steady state of medication and helps to control pain better. Patients who are admitted, do not forget the bowel regimen with stool softeners, incentive spirometer, which is very important, and monitoring, close monitoring. Acute chest syndrome. So that's another complication that we see, and the frequency and the severity of these episodes can gets worse as you grow older. So it's basically a sickle cell crisis in the lungs that happens. So it's characterized by fever, respiratory symptoms, shortness of breath, tachypnea, chest pain, hypoxia, along with a new infiltrate that can be seen on the chest X-ray. It's the etiology is multifactorial. In children, basically infections have been shown to trigger an acute chest episode, and it could be viral infections or bacterial infections like mycoplasma. In adults, it's can be chlamydia infections that can trigger that. Fat emboli, so VOCs, so pain crises within bones can cause bone marrow necrosis and release of these fat emboli, which can trigger an acute chest episode. Pulmonary embolism. So acute chest syndrome may be complicated by pulmonary embolism or may occur secondary to a pulmonary embolism. So in either of these cases, both the pulmonary embolism and the acute chest should be treated, meaning you need to do anticoagulation along with managing the acute chest syndrome. Hyperventilation secondary to post-operative use after general anesthesia, opioids, or rib pain or pain infarct in which patients are in which there's splinting that is happening, can result in pulmonary atelectasis, hypoxia, and intravascular sickling, which causes microvascular occlusion and pulmonary infarction. So this is a little bit different from a PE, but there is microvascular occlusion and decrease and in pulmonary tissue infarction that happens over here. Fluid overload can also trigger it with pulmonary congestion and edema. Asthma, so higher incidence of acute chest has been shown in patients who've got asthma, and they can present at a younger age. And bronchospasm has been thought to contribute to the local hypoxia. So if you look at the spectrum of symptoms that's seen in children and adults, children usually present with fever, cough, respiratory symptoms. Pain is not a predominant symptom in children, While in adults, pain and dyspnea are the dominant features. As we can see over here, adults usually have a longer duration of symptoms and more severe course, and the mortality rates are higher. So either it can have a slower course, but there is a chance that it can progress very quickly. So there is a phenotype that's called as rapidly progressive acute chest syndrome, in which you see worsening of the respiratory status in less than 24 hours. There is worsening in anemia. It is multi-system. So as in, you can also see acute renal injury with increased creatinine, decreased urine output, hepatic dysfunction, neurological symptoms can be there. A decreased platelet count at admission is the only predictor of it having such a severe course and becoming a rapidly progressive phenotype. So that's the predictor. So can stroke happen with acute chest syndrome? Yes. And as I showed you earlier, this can happen during acute chest syndrome or even within 2 weeks of an acute chest syndrome. Hypertension is a bad sign. So most cases of stroke associated with acute chest had hypertension. So how do we manage acute chest? Do not do normal saline boluses. You want to give fluids, but do not flood the patient with fluids. So IV fluids around 3/4 maintenance should be done. Avoid overhydration because it can worsen the pulmonary edema. So at our institution, we start ceftriaxone and then we switch to ampicillin, which is given for, or when they get discharged, it's switched to amoxicillin to be given for a total of 10 days. Azithromycin is also added for 5 days. So when should we consider transfusions? It depends on the patient's oxygen requirement or whether they're markedly anemic. So to decide between simple or exchange transfusion depends on how bad. If it's like a complete whiteout on the X-ray, then and they're progressing really fast and requiring escalation of respiratory support, then you should consider exchange transfusion. And also depends on the hemoglobin concentration. So if the hemoglobin is already pretty high at 9, you should just do you should do an exchange transfusion at that point. Versus if the hemoglobin is lower, you can do simple transfusions. Make sure the pain is well controlled, because that can also cause worsening splinting and then more atelectasis. Bronchodilators have not been shown to be beneficial in everyone, only if you've had a history of asthma and reversible airway disease. In those patient population, bronchodilators should be tried. Very important to do IS and central spirometry, encourage ambulation, and if patients are like admitted to the ICU and it's a prolonged course, you can consider DVT prophylaxis while they're inpatient. Avoid Toradol if there's any concern for acute kidney injury. All right. So the next complication is priapism. So in here, what happens is this is basically an ischemic or a low flow priapism that is seen. So sickle cells obstruct the venous outflow of the corpora cavernosa, which is the erectile tissue. So there is venous stasis that happens over here, resulting in a compartment syndrome kind of picture with acidosis, hypoxia, ischemia, which kind of worsens it. And there is a decreased flow in the cavernosal vessels. So this can result in pain and permanent damage if it lasts for a longer time. So the first episode usually occurs during early puberty, and they may continue into their 30s and 40s to have these priapism episodes. The prevalence is around 5 to 45%. So the cooperative sickle cell study showed, the data from the study showed that affected patients had higher rate of hemolysis. So that could be a risk factor. Prolonged priapism more than 4 hours can result in erectile dysfunction, infertility, progressive fibrosis. So if it's lasting more than 4 hours, urology should be consulted and intervention should be done. So stuttering priapism episodes are the ones that are intermittent, they are self-limiting, but they are recurring and they can last from more than 30 minutes to less than 2 hours. And they can develop into an acute episode, which lasts longer. So usually they're managed at home with hydration, warm baths. If they're already on Sudafed, they should take that. But if it is sustained more than 2 hours, they should call us, they call the ER. and they're usually pretty painful. And in the ER, they usually manage with fluids, oxygen, pain management. But if it starts being more than 4 hours, that's concerning, and urology should be consulted. And usually they do aspiration and saline irrigation to detumens that area. And but if it's refractory and not responding to the aspiration, as you can see over here, then surgical shunt and prosthesis can be done. Regarding transfusions, there is Aspen syndrome has been reported, in which there's a risk of neurological symptoms that can occur with exchange transfusion. So the take-home message is that if it's lasting more than 4 hours, urology with aspiration and saline irrigation is the preferred thing that should be done. In adults, there's a slight shift, and you can see that cardiopulmonary complications are the leading cause of death in adults with sickle cell, and followed by renal complications. So I've just talked about a few of them. So sudden death can be from myocardial infarction, pulmonary thromboembolism, pulmonary hypertension. So the etiology of this myocardial infarction is not really clear, because the epicardial coronary vessels are actually clear. There's no atherosclerosis that is seen. And it's thought to be because of acute chronic microvascular occlusion that's happening, which can result in infarction, myocardial ischemia and infarction. So diagnosis is difficult because chest pain is reported in majority of the patients, and this can be confused with other causes of chest pain, which could be just a pain crisis, rib infarction, or gastritis from NSAID use. So, and traditional tools like ECG are not very sensitive to diagnose myocardial ischemia because they can have non-specific findings. Troponins are pretty specific, and cardiac MRI can also be used. So how do you manage an acute MI event? It's usually treated like a pain crisis again. Hydration, oxygenation, pain control, and transfusions should be done. A study showed that receiving a simple transfusion, exchange transfusion, actually decreases the chance of a recurrence in the next 3 years. So it is shown to be beneficial. Nitrates might be helpful, but the more studies are needed to support this. And evidence-based guidelines for use of antiplatelet agents, anticoagulation, and thrombolytics is lacking. So the last one is renal failure. So sickle nephropathy is also one of the leading causes of mortality in adults. And this renal dysfunction starts early in life, and it's got a wide range of spectrum, starting from like hyposthenuria, albuminuria, resulting in acute renal failure and chronic kidney injury. So incidence of acute renal failure and chronic kidney disease is about 2 to 3-fold higher in sickle cell patients compared to non-sickle cell patients. And this has acute renal failure episodes have been shown to be associated with higher mortality and healthcare utilization. And the predictors are usually older age, presence of proteinuria, diabetes, hypertension, chronic heart disease, and blood transfusion. So as we can see that this is a multi-system disease, and you have virtually all organ systems affected, and the frequency and severity of these complications worsens with age. Some complications are present throughout age, some appear later on in age, and this is ongoing injury that's happening. So here I've tried to cover some of these complications. There are way more, but this is just as quick summary as possible. That is possible. All right.
Thank you so much, Dr. Rai. This was excellent. I think that you're right. There are so many, and so many things to talk about, but you really hit on some high level complications that we do see regularly. So thank you very much. We'll take questions at the end. I'm going to introduce Yvonne Carroll. Again, she is an RN from St. Jude with a very lengthy history in sickle cell advocacy. We are so grateful to have her here. She spoke at last year's Management of Sickle Cell Complication Symposium on clinical trials, and she will now present on barriers to participation in sickle cell clinical trials. Yvonne, I believe you can take control of the screen.
Okay, give me a minute. I just lost can you hear me?
I sure can.
Okay, I just lost my share screen.
Okay, let me.
Give me a minute. I'm sorry.
No problem.
Here we go. Okay. All right. I want to thank you for having me. And let me get to my slideshow. Thank you for having me. I also just want to give a shout out. I'm a board member too, as well as being the director of patient services at St. Jude for the International Association of Sickle Cell Nurses and Professional Associates. So anybody who's interested, I'll have the website up at the end of the talk. And I also want to thank the Leaks Incorporated for their funding. St. Jude, they give a legacy grant every 4 years of $1 million. And part of what this, they are helping support this today, but part of also what they're doing is in Nigeria, they are funding the start, help funding the start of a newborn screening clinic. And you know, in all 50 states now we have newborn screening, but they don't have it in Africa, in most of Africa, which is where most of the patients live with sickle cell disease. And this is just a little quick, and I apologize, but this is the only way I can show this video. I've tried. And it's just a quick video. So again, thanks to Links and to St. Jude for helping this happen. So let's get on topic. Health disparities and unconscious bias in sickle cell clinical trials. What do they have in common? Well, first of all, let's talk about what is a health disparity. So health equity and health disparity are pretty much two terms that are inseparable. So health equity is when someone has the opportunity to be as healthy as possible, which we all should have that opportunity. As we know, we don't. Health disparity is the difference between health outcomes between different groups of people. So if you have a group of whites and a group of blacks, if they have the same disease, you would expect the same outcome. As has been brought to the forefront, many of you living with sickle cell disease know that this is not, this doesn't happen. But I think now the wider population is beginning to understand the health disparity for African Americans and people of color. So the CDC put out a very, very nice flyer that basically kind of just talks to several health disparities and health resource disparities for people with sickle cell disease. So first of all, the life expectancy is shortened. We all know that people with sickle cell disease have a reduced life expectancy, up to 20 to 30 years shorter than people without sickle cell disease. But what's interesting, they also have the highest rate of returning to the hospital within 30 days compared to people with other health conditions. So that's very surprising, and health disparity which shouldn't happen. The rate of strokes in adults is 3 times people with African Americans who don't have sickle cell disease. But also, let's talk a little bit about health resources. The majority of people with sickle cell disease are Medicaid beneficiaries. Up to 70% of doctors don't accept Medicaid. So we all know of someone, if we know people in the sickle cell community, when you have to search for doctors, do you accept my insurance? Do you accept Medicaid? And this is especially an issue with the transition from pediatric to adult care, because people, insurance changes, and while most people accept pediatric Medicaid, a lot of them don't accept when they become adults. They have a longer wait time to see the doctor. So this goes to bias, and which we'll talk about in a minute. But many people, as I'm sure you know, people with sickle cell disease will tell you that they have experienced bias in the waiting rooms, and they had to wait longer, and people don't believe that they're in pain. People think that they're drug seekers, and it's real. It's been studied, and it exists in our community. And then you have the number of physicians who are trained to treat people with sickle cell disease. We have HEMONC training. So our hematologists and our oncologists are trained together. And what this means is that they have a choice as whether to go into oncology or hematology. We have a severe shortage of doctors, of hematologists who treat sickle cell disease, especially adult hematologists. Additionally, we have a severe shortage of African American and doctors of color. And as we all know, research has shown that people have more compassion when they're treating someone that is familiar to them. And so there are a number of health disparities based on resources and outcome for people with sickle cell disease. So what's bias? Bias, we all know, is attitudes, behavior that are prejudice one group in favor of another group. So implicit or unconscious bias is when you don't do it intentionally. It's just something in your subconscious. Something, if you, they've had many tests where you show pictures of people and you have certain reactions. It might be the way people wear their hair, or it might be the color of their skin, or it might be the way they speak. It's just a bias that you have that's ingrained that you're not consciously aware of, but it does dictate your actions. So how can we relate that to sickle cell disease? One study showed that 63% of nurses incorrectly believe that addiction was prevalent among people with sickle cell disease. Now, we all know the opposite is true. They actually have a lesser rate of addiction than the normal average population. But the fact that nurses or doctors may perceive that they have a higher rate may prevent getting pain medication in a timely manner. Another one is that caregivers, they reported their perceptions of stigma, and not only in the medical field, but in academic, which means at school. And this is real in the sense that a lot of people with sickle cell disease who are students don't want to admit or tell people that they have sickle cell disease. The school, the nurse, their classmates, and this can be detrimental to health. The community at large. I talked to a minister of a large African American church, and he said, you know, I had forgotten about sickle cell disease because it was really high on the radar in the 70s and kind of went away. And now, luckily, it's coming back on the radar. But even in family settings, people don't want to tell extended family because they're afraid of bias. They're afraid of what people might think and perceive. And this affects how they share their disease, and it can affect the resources that are available to them. So what does health disparity, unconscious bias have to do with clinical trials? First, let's talk a little bit about what are clinical trials. And so they're just the way you take a drug or a device from an experimental stage to being a stage where you can present it to the public. So the first, before you even get in the phases talk about experiments on humans. You have your preclinical trial, and your preclinical trial is basically discovering what the drug is or what the device is. So after you get something in your preclinical trial and you say, hey, this might work for sickle cell disease or another disease. Then you go to phase 1. And so your phase 1 is really where you talk about and you find out, is this drug safe? Does it have side effects? I mean, it might, cure the disease, but it might be fatal to the individual. So of course that wouldn't be a drug that you can use. That usually has about 20 to 80 participants, and usually those are all healthy adults. Phase 2, after you get past, is it safe? Then you have to go to, does it work? If it doesn't work, if it doesn't do what it's supposed to do, even though it's safe, it's still not a viable drug. You can't use it if you think it's going to reduce pain in people with sickle cell disease, and it shows that it doesn't reduce pain in sickle cell disease, then it's not it's not a good drug. And so you lose about 2/3 of the drugs in stage 2. In phase 2, you find that it doesn't do what it's supposed to do. And you have about 100 or more to 300 people in that. Phase 3, so you've done phase 1, you found it safe. You've done phase 2, you found out that it actually works. So you go to phase 3, and this is larger, where you have about 1,000 to 3,000 people. And so this is where you want to confirm the effectiveness in a larger group of people, and you want to monitor the side effects. And you also have to compare these side effects to other treatments. So it might be effective, and it might be relatively safe. But if you have a drug out there that's completely safe, which there's no such thing, but say it's much safer than the one that you're proposing, then you probably won't get approval for that drug because it's not benefiting the population. And this phase 3 is where you collect all your information, and then you submit that to the FDA, and the FDA determines whether it should go out to the general population at large. And that's phase 4. So phase 4 is where the general population, doctors can prescribe this drug, they can give it to people, but you still collect information because sometimes in the past, drugs have had long-term effects, or say there have been certain drugs that have effects on the fetus, or certain drugs that may have been prone to cause cancer in people. So those you can't, those are not short-term studies. Those are things you have to find out in the long run. So those are the basic 4 phases of a clinical trial. So let's take a look at the current example. I mean, COVID-19. Clinical trials. How does health disparity and unconscious bias affect it? So we know that COVID-19 for people of color, for Hispanics, they're 4 times more likely to be hospitalized than whites who have COVID-19. We know that Blacks are 5 times more likely to be hospitalized, and both groups are 2 times more likely to die from COVID-19. So this is a huge health disparity. It's been all over the news. Everybody's heard about it. Everybody's aware of it. And there are about 20 trials that are going on now. Everybody's trying to find the vaccine for COVID-19. But we've had results from a couple of trials so far. So let's look at the first results. This is from Moderna, which is a company in the US, and they had phase 1 trial. They gave their results. And so when I was looking at the results, I wanted to see what the enrollment group was. So we know that people of color are more likely to get it, more likely have increased mortality and morbidity. They had 45 people in the study. And let's look at, when you look at this, the Blacks, they had 3 groups, and they gave a low dose, a medium dose, and a high group. So let's look at the first group, 0 Blacks. The second group we'll come back to, and the third group, 0 Blacks. So 2 of the 3 groups that they were testing for safety had no Blacks. Latino, 1 Black, 1 Latino. We'll come back to the second group again, and 2 in the third group. But let's look at the second group. If you add the numbers, there's a group of 15. If you add those numbers, starting at the top, American Indian or Alaska Native, it comes to 18. So what does that mean? Some people were double reporting. If you look at the number of Black and Hispanics, the Blacks had to be reported as Hispanic Blacks, which means in all three groups, basically there were no non-Hispanic Blacks. What does that mean? We won't know the safety of this and how it affects Blacks. Also, the study was done part in Seattle, part in Atlanta. Atlanta is more than 50% Blacks. You almost have to go out of your way not to have Blacks participate in a clinical trial in Atlanta. So let's look at the second study that we had results on. This is an Oxford study in England. It was a phase 1/2 clinical trial. They had 1,077 people, 1,077, 6 Blacks. And they didn't break it down for Hispanics, so we don't know with Hispanics. So the group that has the largest mortality and morbidity, the greatest mortality and morbidity from this was not included in the clinical trials. So part of this study was, the way they advertised was to put in the local news. We all know, and local advertisements, we all know that people of color have different methods of communication. They don't watch news, they don't watch normal TV. Usually they're streaming or watching BET or Latino networks. It's a different way of communicating. They also had that people, as an exclusion criteria, people who were more likely to get COVID-19 were excluded from the trial. So if you live in a multi-generational household, or if you work on the front lines as a server or a driver, which so many people of color work, you were automatically excluded. These are things that can be, that if you have people of color involved, that they can help negate much of the unconscious bias from clinical trials. So what affects clinical trial participation in the minority population? Mistrust. So we have all heard about the Tuskegee trial, where 600 Black men were studied, started in the early 1930s, and 2/3 of the men had syphilis. And it was a trial to, and by the way, these people were given, now this, think about this, this was during the Depression, and a lot of people out of work, a lot of people didn't have food. So they gave free food, burial service, and free medical care. They didn't tell the people that they had syphilis. They didn't get consent from the people. They told the people they were treating them for bad blood. So they studied these men, and about 10 years after the study began, there was an effective cure for syphilis. They did not give the men the cure for syphilis, and they continued to study them for another 30 years until in the 70s, someone got wind of it, and it was such a large outcry. But of course, by that time, many of the men had died or suffered such morbidity that they couldn't be helped. So there's huge mistrust, and there's just a plethora of examples such as Tuskegee's that have been done on people of color. Communication. We already talked about communication. It is, it's different for people of color. So if you use what's considered standard methods of communication, you're going to miss people of color. Lack of accessibility. That is the, many of healthcare providers are, one, moving out of areas that have large concentration of people of color. They want to go to higher income areas. And two, what we talked about, and people not being able to access medical care. if you have Medicaid and the doctor doesn't accept Medicaid, you can have a doctor right next door, but it doesn't matter. And then economic factors. So clinical trials don't exist in a vacuum. We all live in the real world. We like to think we can come to the doctor and nothing else will matter, but we know that's not true. Education. If you have a lower education, illiterate, you don't understand what's being told to you. If the doctor is not breaking it down to a level where you can understand it, it's not going to do much good. Income. 16% of people with disabilities are employed. And we know that if you have disability income, that you are prevented from earning over a very modest amount of money. And so what does that do? That means you're put in lower income jobs. You can only work part-time, but you just enough money so you're not eligible for food stamps. You're not eligible for any other benefits. So it's almost like the system was designed to make sure you stayed on it, because if you get off of it, you lose what? You lose your medical care. And people with disability have to have medical care. Jobs, we talked about that. Housing. Housing is huge for people with sickle cell disease. If you don't have a steady place to live, if you're homeless, or you live in a multi-generational house, or you are rooming with someone, or you're renting a room, those things affect your participation in clinical trials. If you're worried about the basic necessities, you're not going to be interested in, yeah, let me go participate in this clinical trial. Geography, we can spend a whole day on talking about redlining and how minority populations were put in poorer areas where you have more pollution, you have more dump sites. Studies have been shown if you live in certain poor zip codes, you are at higher risk for cancers, you're higher risk for stress. We know stress impacts sickle cell disease. So geography affects people with sickle cell disease. The criminal justice system, that's self-explanatory. And we talked about access to care and racial inequity. It's all over the news now. And if you're in the sickle cell community, you know that there's a huge racial inequity anytime you go to the hospital. So how can I help myself? How can you help? The first thing is knowledge. And I'm gonna tell you, the first thing is you are not an island. You have to reach out for help. You have to engage resources that are available and try to get new resources. Try to talk to people at the hospital. Come up with ideas. Get in with your local community-based organization. Come up with different new ideas. Once people, it's a matter of perception. We know perception makes a huge difference. If you are a part of a group that they're saying, hey, let's do this different with sickle cell disease. Let's try this pilot with sickle cell disease. I'm gonna give disclosure here. I'm on the advisory board for one SCD voice, but it is I'm telling you, it's a wealth of information for people with sickle cell disease. And let me get out again, see if I can do this. Bear with me. For some reason, I can't get my video to work with in screen. But if you see as a scrolling down, it's just a huge amount of information. It will take you out to get all of this information. All of this information, you can go, and it's just a place that coordinates information for you. So one SCD voice is just, if you want education about clinical trials, this is just a place where you can go, and it's consolidated in one area for you. Also, clinicaltrials.gov. As you can see, there are 780 studies on sickle cell disease. Now, not all of them are going to be active. Not all of them are going to be recruiting. Not all
Hello, everyone. Please hold tight. It looks like that we just lost a connection, and we'll be right back with you. Good information it was. Let me just make sure that we still can keep her in. Again, you're watching Sickle Smart Summer. This is the July session. We have been talking about acute complications across the lifespan for sickle cell disease. We're currently hearing from Yvonne Carroll of St. Jude Medical Center, and she is speaking on disparities, bias, and barriers to participation in clinical trials. And it looks like we may have Yvonne back.
Okay, great. So can you hear me now? Can you hear me?
Yes, I can.
Oh, okay. It's like that commercial. Okay. So can you see my slides?
No, not yet.
All right, let's see if we can. I apologize.
That is okay.
This is called the real world, isn't it?
Otherwise, I can bring it up on my end as well.
I think I can do it. Let's see. Okay, you should be able to see it now.
Yep, I can see it.
Okay, so and that's the next to the last slide, so we're close. Slideshow from current slide. So how can institutions and drug companies help? Think outside the box. Think about how drug trials can be made more accessible to people. If it's not just at one institution, keep the way you're doing it, but also add something else. Maybe a regional area coordinating center where you can go to your regular doctor and get all the lab tests you need, and then go to the coordinating center for things that you have to have for the trial. Think about after hours. A lot of people have children they have to pick up from school. They work, they can't have jobs where they can't miss work. Home visits, telemedicine. Communicate, use people you trust to deliver the message. We talked about that using influencers. There are sickle cell disease influencers you can use. We talked about the alternative mediums you can use. And then just be honest and caring. People can sense that. If you're just there because you want someone in your study and you want another academic paper, people can sense that you aren't really there because you care about them. And then train or incentivize more minority physicians. There is such a low rate of minority physicians that it is almost unbelievable in 2020 that we haven't improved in this area. And then, of course, reimburse adequately for time, transportation, childcare. And then one of the biggest things that I've heard is that people don't get results. Let people know the results of the study. They want to know that they have been part of something that has improved care, even if it doesn't improve care for them, if it improves care down the line for other people with sickle cell disease. So I want to thank all the people with sickle cell disease who have given me insight and their time, their caregivers, healthcare providers who are extremely dedicated, and people around the world who are making a difference during this time of social unrest and in our pandemic. And I also want to thank Iasca Napa, the Nursing Association, St. Jude, and the Lynx Corporation. And I think you said we'll have questions after, but that's my contact information if anybody wants to contact me, and also if you want more information on Iasca Napa. Thank you.
Thank you very much, Yvonne. This is excellent. Let me make sure that, there we go. All right, you can stop sharing your screen. And
Okay.
thank you so much. That was incredible. You actually walked us through from disparities to bias to how those things particularly impact clinical trial participation. And so again, we talk a lot about trust here at Sickle Cell Foundation of Minnesota. We know that we have a very, when you look at other places across the country, our numbers of not just sickle cell patients, but just the African American population. We have concentrated poverty. We know that the tragic murder of George Floyd, which happened here in Minnesota, we know that it really spotlighted the disparities that are happening in our state and have been happening for a very long time. I also appreciate that you talked about the lack of providers of color, and specifically Black and Brown providers, because that goes a long way to increasing trust on the inside of the healthcare institutions. And so thank you very much for boldly bringing to light, once again, those things. Our next presenter I'm very excited about as well. It is Dr. Angie Smith of University of Minnesota. She's been a transplant physician at the U for a very long time, and we love that, and is an incredible source of knowledge. And so I'm very happy to have her presenting. Some of you in Minnesota and abroad may have even met her before or seen her at many of the conferences that are happening around the country. So I will let you take it from here, Dr. Smith.
Okay, great. Can you guys hear me?
Yes, I can.
Okay, perfect. And now I should be sharing my slides. Can you all see them?
Yes, yeah? I can see them.
Okay, perfect. Great. So thank you for that introduction and for inviting me here today to discuss curative therapy for sickle cell disease. So as Ray mentioned, I am a transplant physician at the University of Minnesota and have been involved in transplant trials and more recently gene therapy trials for patients with sickle cell disease. So what I'm going to talk about today, I'll just briefly do a sickle cell disease review, much of which you've already heard today and on other previous days of this seminar series. And then I'll spend time talking about two potentially curative therapies for patients with sickle cell disease, including stem cell transplant and gene therapy. So what is sickle cell disease? It's a genetic hemoglobinopathy. The way that it is passed down in families is through our DNA. We get half of our DNA from mom and half from dad. When mom and dad are both carriers, patients can end up with sickle cell disease. So from a genetic standpoint, sickle cell disease is due to abnormal beta globin subunits. We can have two sickle globins or sickle beta globin and then beta thal combination. So hemoglobin is in red blood cells and it functions to carry oxygen throughout the whole body. Red blood cells, normal red blood cells look like here. They're disc-shaped. They can easily move through blood vessels but patients who have hemoglobin SS disease have red blood cells that have a tendency to sickle. And when these red blood cells sickle, their lifespan is shorter and they can block blood flow to parts of the body, leading to all of the clinical manifestations of this disease. So here's just a pictorial representation of that. So here on top, you can see normal red blood cells. They're disc-shaped. They can easily squeeze through small blood vessels. And then in sickle hemoglobin, those cells are misshapen. They stick together. They clog up small blood vessels. This causes infarction and the clinical symptoms that we see. So, you know, as Dr. Rai pointed out in her presentation earlier today, sickle cell disease really affects every organ in the body. So strokes, retinopathy, splenic sequestration, autoinfarct, heart disease, dactylitis, from a lung perspective, pulmonary hypertension, acute chest syndrome, and kidney disease, but of course, many other things, most of which Dr. Rai already spotlighted, so I won't spend time here. She also, in Dr. Rai's presentation, is you know, just a representation of where we've come from in treatment for sickle cell disease, and that we have much more work to do. So you can see this increase in median survival for patients with sickle cell disease over you know, the late 1900s, really due to newborn screening, prevention with hydroxyurea, transfusions, immunizations, and then just better recognition and treatment of complications. But clearly, we have more work to do. So what are the current treatments that are available for sickle cell disease? Notably, these are treatments, not curative therapies. So newborn screening, very important. Thankfully, we have that in all 50 states here in the United States, in the US, but that is helpful for early intervention so that we can educate these families about hydration, about splenic sequestration, about other triggers for red blood cell sickling. Hydroxyurea, which increases fetal hemoglobin and can decrease symptoms of sickle cell disease. Transfusions, either simple or exchange. So you're giving a patient red blood cells that don't have hemoglobin S and don't sickle. And then, of course, immunizations and preventive antibiotics. Of course, there are downsides to these, and these treatments aren't always easy. Hydroxyurea doesn't work for everyone. It requires you to take a medication every day. Transfusion programs are time consuming. It requires coming in to the hospital or the clinic on a regular basis. You can get iron overload. You can get alloimmunization. And then, you know, from a prevention, immunization and preventive antibiotic perspective, again, requires you to take a pill twice a day, doesn't always work. So of course, you know, people have been looking for better treatments for sickle cell disease, many of which I'm not going to talk about, but we've also been working on more curative therapies as well. So speaking of curative therapies, we'll move on to that right now. So we've already talked a little bit about what causes sickle cell disease. So the hemoglobin SS genes make sickle hemoglobin, which are incorporated and cause red blood cells to sickle. So how do we cure sickle cell disease? The way we do that is we need to get rid of those sickle red blood cells and hopefully replace them with normal red blood cells. So there are two potential options for cure. One is to permanently replace the red blood cells with donor red blood cells, and that would be hematopoietic stem cell transplant or bone marrow transplant. And the other is a newer therapy that's being implemented, and that's gene therapy. And essentially what we're trying to do is replace the gene that doesn't work or edit the gene that doesn't work so that normal red blood cells are made. So looking at transplant first, because we have the most experience with that. We've been doing transplant for sickle cell for decades. So what is transplant? Again, it's known by a lot of different names. Stem cell transplant, bone marrow transplant, but essentially what we're doing is we want to replace the blood making ability of the patient's bone marrow. And so inside the bone marrow, we have stem cells. Hematopoietic stem cells are the cells in the bone marrow that can make more of themselves, but they can also make all the different types of blood cells. So red blood cells that carry oxygen through the body, the white blood cells that help fight infection, and platelets that help your blood clot. Now, patients with sickle cell disease don't have problems with their white blood cells or platelets, but we can't just replace red blood cells. And so for a transplant to be successful, we have to give them donor stem cells that can make all the different types of blood cells in the body. So how do we do this? Well, we have to give them chemotherapy, plus or minus radiation. And the reason we give those therapies is really to create space in the bone marrow and to immune suppress the recipient so that they can accept those new cells from the donor. And that currently the only way we know how to do that is using chemotherapy, because one of the side effects of chemotherapy is that blood counts go down. And so we use that side effect to help the transplant process. People are working on lots of new ways to get rid of the bone marrow that do not include chemotherapy or radiation. And hopefully we'll have other things to use in the future, but currently chemotherapy plus or minus radiation is the mainstay. So you create space in the bone marrow, you suppress the immune system of the recipients, and then you give new healthy hematopoietic stem cells. And these stem cells provide a sustained source of all the blood cells, including red blood cells, so that you can decrease the amount of hemoglobin S in the body from whatever level they started at to 0 if you're using a donor that does not have trait, or to trait levels if you're using a sibling, for example, who has trait. So you can see here in this schematic, we have a patient with sickle cell disease. We give them chemotherapy. We infuse these stem cells. And where do we get the stem cells? So there are several different places we can go to look. One is siblings, so that's the obvious place to look. And the other is the unrelated donor registry or the umbilical cord blood registry. So these stem cells we can find again in the bone marrow, we can find them in peripheral blood, and we find them in umbilical cord blood. And we'll talk a little bit about how we choose a donor. But essentially you infuse those stem cells, those new stem cells start to grow in the body, and then you know, at the other end, you have a healthy patient who makes normal red blood cells. So what is the history of transplant for sickle cell? So the proof of principle occurred not because people were trying to cure sickle cell disease, but because a patient with sickle cell disease developed leukemia and needed to undergo a transplant. And that patient had a sibling donor and underwent transplant, which cured their leukemia and also cured their sickle cell disease. So over the years since that time in the 80s, we have done transplant for a good number of patients with sickle cell disease. You can see here I've listed some of the outcomes. I mean, obviously the outcome of overall survival is very important because we know that this process of transplant can be a very difficult one and comes with potential complications that can be life-threatening. So this is a very important outcome that we need to look at when we are evaluating how transplant works. Of course, then surviving without sickle cell disease is the cure. And so event-free survival or sickle cell-free survival also is a very important piece to look at. And then one of the big complications that we worry about with stem cell transplant is graft versus host disease. So that's where the donor cells start attacking the patient's cells because they see them as different or foreign. And it can be pretty severe and again, can be life-threatening. So minimizing that in patients with sickle cell disease is of high priority. We can see here matched sibling donors. using chemotherapy. So the conditioning is what we call the chemotherapy and or radiation. There are different intensities that we can use. Myeloablative means very high doses where we're really getting rid of all of the bone marrow. While this is helpful to provide good engraftment of the donor cells, it can also be pretty toxic to the patient and can cause them to get really sick. And so for patients with non-malignant diseases like sickle cell disease, we often try to decrease the intensity of the chemotherapy that we give them so that we can lessen side effects. The risk of doing that, though, is that the graft failure rate will be higher. What we've seen in patients with sickle cell disease is that's not necessarily true. So we have excellent overall survival, we have excellent disease-free survival, and a really low rate of graft versus host disease. So clearly an unaffected matched sibling is the ideal donor for patients with sickle cell disease. However, as we'll learn about in a bit, less than 20% of patients with sickle cell disease have a sibling who's available and healthy without sickle cell disease to be their donor. And so this is not an option for the vast majority of patients. Haploidentical transplant is something that has been around since the beginning of transplant, but really has made a resurgence in the last 5 or 10 years, in part due to improving techniques in how to decrease this risk of graft versus host disease. Haploidentical means half match. And so again, family donors, most people have a half match donor. Usually a parent can be a half match donor, or by theory is a half match donor. Siblings can be a half match. And so most people have a parent or a sibling who are available and willing to donate. And so this type of transplant then opens up this curative treatment for a much larger population of patients. Early studies looking at haplotransplant showed really good overall survival, but the disease-free survival wasn't great. And what that means is patients experience more graft failure. But with newer techniques and something we're doing at Minnesota and people are doing at other places as well, we've really upped that disease-free survival rate to being closer to that of a matched sibling donor. So I didn't talk a ton about unrelated donor umbilical cord blood, in part because unrelated donors are really actually quite hard to find for patients with sickle cell disease. I'll talk about that on the next slide. And then umbilical cord blood has been used and has been tried in patients with sickle cell disease with mixed outcomes. There's a higher risk of graft failure using umbilical cord blood. And so that generally tends to be the last choice as a donor source for these patients. So how do we find donors? Well, we have to do HLA matching. So HLA proteins are part of your DNA. We can easily test for them by a simple blood draw or a cheek swab. And essentially what these HLA proteins do is they help us recognize self versus foreign proteins in the body. So we should get half of our HLA genes from mom and half from dad. So again, we can easily look at this matching. So I talked a little bit before about sibling donors. So statistically, you should have about a 25% chance of having, or each sibling should have a 25% chance of being a match to another sibling. But in the case of sickle cell disease, we also have to take into account whether or not they also have sickle cell disease. Clearly, we wouldn't want to use them as a donor in that situation. And so, the reality is it's really, less than 20% of patients who have a matched sibling who can be a donor. A question we get a lot is, would you use a sibling who has sickle cell trait? And the answer is absolutely. In the vast majority of cases, we can easily do that. Patients with sickle cell trait have about 30 to 40% hemoglobin S in their blood. We know that most patients with sickle cell disease are quite healthy and do not have the severe side effects that those with higher hemoglobin S levels have. And so given that we know outcomes with sibling donor transplant are better than those with unrelated donor transplant, we will certainly use a sibling with sickle trait over any other donor source, unrelated donor source that we have. And then talking a little bit about unrelated donors, there are many unrelated donor bone marrow donor registries around the country, around the world. The big one in the United States is Be the Match, or the National Marrow Donor Program. And they facilitate the vast majority of unrelated donors for patients in the United States. They have an inventory of, I think, 26 million or something potential adult volunteer donors that have been HLA typed, and we can query that registry for matches. Unfortunately, finding a match within this registry really depends on your ethnicity and your race. Because these HLA genes are passed down within families and within ethnic groups, and the majority of people who are in the registry currently are white Caucasians. And so in patients who are white, you can have about a 70% chance of finding a fully matched unrelated donor bone marrow donor. Unfortunately, for patients who are Black, African American, mixed race, have a much lower chance of finding a donor, less than 20% in most cases. And so there have really been a lot of outreach to these communities, and Be the Match has really made an effort to help recruit a more ethnically diverse pool of donors. So who comes to transplant, or who is eligible for transplant? We can't take everyone who has sickle cell disease to transplant, because there are a whole host of complications that I'll talk about that can happen with transplant. And so we have to weigh, the risks and benefits based on what symptoms they're having with their disease. So there are clear established indications for transplant, including stroke, including high risk for stroke with increased TCD velocity, frequent vaso-occlusive crises, priapism, acute chest syndrome, alloimmunization from multiple blood transfusions, osteonecrosis. Other potential indications are listed here. Pulmonary hypertension, silent infarct, other organ damage from sickle cell disease. And so it's not a clear line in the sand about who can get transplant and who can't. Part of it is, what donors does a patient have available, because your risk for complications and your chance of success is really dependent on what donor you have. It's also a conversation that we have with families about risks and benefits. And some families and patients are really willing to take these extra risks, knowing that the potential outcome of being cured of sickle cell disease will hopefully improve their overall quality of life, and more importantly, or not more importantly, but as importantly, quantity of life as well. But we also have to remember that, again, sickle cell disease affects all organs. It's a chronic disease. We have accumulation of effects from organ damage over time. And the outcomes of transplant can be affected by how much organ dysfunction is already present at the time of transplant. So what I tell my patients who come for consult is that my goal with transplant is to stop further damage from happening. In most cases, we can't reverse damage that's already happened, but we can prevent further damage from happening. That's an important piece to know. It also makes determining timing of transplants a little bit hard because, again, you know, the complications that happen in sickle cell disease are not predictable in general. And so it's hard to know if and when a patient excuse me, is going to start to have these complications. You know, in recent years, as I mentioned previously, we've been trying to shift to less toxic regimens for conditioning. And therefore, we've really kind of been able to offer patients with less severe disease transplants if they have a good donor. And it's really important, again, to try to move towards transplant before too many complications have already built up over time. So a quick timeline of what the transplant looks like. So first, you know, we bring the patients in and we do evaluations of all their organ function, looking for hidden infection, looking for complications that we can't see from the outside, really because we want to make sure the patient's in the best shape coming into transplant and to help us understand if they will be able to tolerate the therapy that transplant entails. The patient's then admitted to the hospital where they get chemotherapy and or radiation. Again, this is to create space in the bone marrow and to help prevent rejection of those donor cells. Transplant happens, it's like a blood transfusion. Those stem cells are really smart cells. They know where to go to get to the bone marrow, to start to reproduce, to start to make all the different types of blood cells. However, it does take time. So what you can see here is a schematic showing, you know, this chemotherapy. Generally, the effect on counts happens over the first week after transplant, and then it takes 2 to 3 or more weeks for those new donor cells to start to grow in the body. So it's a long time in the hospital. This early period between transplant and engraftment is where we worry most about complications, but there are certainly complications that can happen, you know, up to 3 to 6 months after transplant as well. Hospitalization is long for transplant, generally 4 to 6 weeks. There are many potential complications that occur, in part related to the chemotherapy, in part related to the immune suppression and not having an immune system, putting you at risk for really potentially bad infections. And so the vast majority of these early complications are reversible, meaning we can treat and give supportive care and get these patients through this, but it can be a pretty miserable period for patients. As we move farther out from transplant, other complications that we see in addition to infection is graft versus host disease. Again, that's where those donor cells start attacking the patient's body and can cause a reaction in really any organ in the body. And then, of course, there's the risk of what we call graft failure. And that means that either you do this and you give the donor cells and nothing grows back, or you give the donor cells, but the body's immune system is strong enough to fight them off, and the patient's own blood cells come back, which essentially means that, you know, the transplant was not successful from the perspective of getting rid of hemoglobin S. And then discharge and return home happens over the next several months. You know, patients really aren't back to normal after transplant until 6 to 12 months. You know, their immune system generally doesn't get back to normal until a year after transplant. But it's these first 3 months after transplant that can be really difficult. So making the decision to come to transplant is not a light decision to make. there are a lot of implications, both for the patient, most importantly, but also for the family and caregivers for these patients as well. So do we do things differently with transplant for sickle cell disease? The answer to that is yes. We know that patients with sickle cell disease are at increased risk of central nervous system complications like encephalopathy, seizures, stroke. There also is a possibility for sickle-related complications like vaso-occlusive events, et cetera, during the transplant process. So we do several things differently. We give our patients hydroxyurea for at least a month prior to transplant. Most patients come to us already on hydroxyurea, so this isn't a new drug for them. And the reason we give that is to help start the process of immune suppression and quieting down the bone marrow before transplant. Before admission to the hospital, we want to get their hemoglobin S level less than 30%, again, to help prevent sickle-related complications in that early post-transplant period. We have higher transfusion thresholds, so we keep the hemoglobin higher, mostly to try and dilute out the hemoglobin S concentration so that, again, sickle complications don't happen during that early post-transplant period. And we keep platelets much higher than we would then for other patients going through transplant. And the reason for that is we know, again, that the risk of bleeding, especially CNS bleeding, is much higher in patients with sickle cell disease than it is with other patients going through transplant. Blood pressure control is extremely important in these patients. So monitoring that very closely. And then anti-seizure medication, because again, they're at a higher risk for seizures for multiple reasons, including blood pressure issues, bleeding, all of those things. So have we made improvements in transplant for sickle cell disease over time? Yes, absolutely. But there's more work to be done. But, you know, I've talked a little bit about most of these. Reducing the intensity of the chemotherapy and the conditioning that patients get through before transplant helps lessen complications, both short and long-term complications. One thing I didn't really talk about is fertility, but fertility can definitely be impacted with chemotherapy that's given with transplant. And that's a big deal for a lot of people. And so giving less chemotherapy, avoiding radiation if we can, are ways that we can help decrease those toxicities. We have availability of more alternative donors. Most importantly, in this case, the haploidentical donors that have really increased the availability of transplant to patients with sickle cell disease. And then, you know, the openness of talking about transplant with families early in life, making sure families know all the options, moving to transplant sooner before lots of irreversible end organ damage has occurred, leads to better outcomes as well. So that's it for transplants. Moving on to gene therapy, and this is a really exciting change in curative therapy for patients with sickle cell disease. And my hope is that gene therapy will really replace transplant for the vast majority of patients, assuming that you know, these final clinical trials that are in the works now are successful and have a good safety profile. So what is gene therapy? Gene therapy is essentially taking the patient's own stem cells, so stem cells from their bone marrow or stem cells from their peripheral blood, and either inserting a normal beta hemoglobin gene in it or trying to correct or edit the mutation that is already in their genes. And this manipulation, this addition of a gene, and this editing occurs in the lab before then you give them back to the patient. So the modality that's really moved forward the most in the last several years is this top gene addition modality. And essentially the idea is to take the gene that you want to insert, so a gene that codes for normal beta hemoglobin, and somehow get it inside that stem cell so that it becomes integrated and part of the DNA. And the best way that we have to do that is by using viruses. Viruses are really good at getting into lots of different types of cells, and so they can help us introduce that DNA into the genome. The most common virus that's used to do this is actually the HIV virus, and that's something that can sound really scary to patients when we're talking about gene therapy. The piece to know is that there's been a lot of improvement in these vectors, these HIV vectors. The parts of the virus that are really infective and that can be dangerous are removed prior to them being introduced into the cells. But viruses is the way that we do that and the way that we get the genes in the cell. So why is gene therapy theoretically better than transplant? There's a couple of reasons. The first is that you don't need to find a donor. The patient is their own donor. We're not introducing a whole new foreign immune system. So you don't need to immune suppress the patient. There's no risk of graft versus host disease. And that really minimizes the complications. The downsides and the limitations are that it still requires chemotherapy. So we're still stuck back at, we need to get rid of the bone marrow and the stem cells that are already in the patient's body so that we can create space and room for those new corrected stem cells to go. People have tried to do gene therapy without chemotherapy, thinking that there would be, a survival advantage for the stem cells that have the corrected beta globin gene, but it just didn't work well. And so we still have to deal with the potential side effects of chemotherapy in patients who get gene therapy. These last two limitations have been decreased in frequency very much over the years that people have been working on gene therapy. So theoretically, you could have a replication competent, so like an active HIV viral vector. So you could theoretically get HIV. Again, this would be really unlikely. And the other potential limitation that really held up gene therapy being implemented in diseases around the world is that the early forms of vectors used for gene therapy would insert themselves into the DNA in areas where they could potentially cause leukemia or other cancer. The new types of vectors that are being used, we haven't seen that, but again, that's something that was seen in the past and is certainly a theoretical risk. So there are there are a good handful of gene therapy trials that are open for patients with sickle cell disease. The early trials, just as Yvonne was mentioning, these early phase 1, phase 2 trials are often done only in adults because really what we're looking at is safety. And there are a lot of protections for children and patients who can't consent for themselves in these early phase trials. So again, just looking at clinicaltrials.gov that Yvonne also pointed out is an excellent place to go when looking for potential options. There's a couple of trials, these early phase trials, again, using lentiviral vectors to insert an anti-sickling beta globin gene. These are all ongoing trials where we don't have results available. Some of the more, these later trials are starting to enroll younger kids. So in this Boston Children's study where they are using a short hairpin RNA to target the gamma globin gene repressor, BCL11A. This is open, I think, at several centers, and again, is now open to kids as young as 3. Unlike some of the trials or the examples that Yvonne was giving about numbers of patients in trials, for rare diseases, we generally don't have thousands of patients to do these studies on, and so smaller number of patients are used. And so these studies are only enrolling 15. And then this current trial, this Bluebird trial, is the phase 3 trial. So this is the one that I think is holding the most promise of being approved by the FDA, hopefully sometime in the next couple of years, and therefore being more available to patients, sickle cell patients who really need curative therapy, but don't have good donor options. So Bluebird has been working on this for many years. Their early phase trials were not as successful as they wanted them to be. And so many modifications were made to the way that the process is done, including where they get the stem cells, how they get them, how they're adding the gene, and how we're preparing patients to undergo this therapy. And so it's a very complicated process, but in the later phase 2 trials, they have been seeing really great success with gene therapy. And so we are excited to be a part of the phase 3 trial that we have open. Unfortunately, it is limited to 35 patients. And so I've seen a lot of patients who really want to move forward with this trial, but for reasons being it's a small number of patients that can be enrolled, but also it's very tight inclusion criteria. We're unfortunately only able to enroll 2 patients here at the University of Minnesota, and we are hoping to move forward with our those 2 patients hopefully in the next couple of months. So again, in summary, curative therapies for patients with sickle cell disease are ever expanding, and we're improving outcomes with them as well. So again, by different stem cell sources, by using less intense chemotherapy and conditioning. But I think the most exciting piece of curative therapy for patients with sickle cell disease is gene therapy. And again, I hope that gene therapy will surpass the use of transplant as curative therapy for sickle cell disease. But of course, you know, there's lots of things that we as transplanters and cellular therapists have and struggle with in patients with sickle cell disease. You know, who should go to transplant? When should they go to transplant? Should we try and wait for gene therapy to be available, given the good outcomes that we've seen? How do we predict who's going to do really great with hydroxyurea and who's not going to do great with hydroxyurea? So these are questions that I think many of us have, and hopefully we'll be able to figure out some of the answers over the next several years, but it's certainly not clear cut. So here's just some information about our transplant program. Myself and Dr. Evans see most of the patients with sickle cell disease who come for transplant or gene therapy consults. Yeah, that's all I have. So if there are questions, I'm happy to take them. I will.
This was fantastic. Thank you.
Yeah.
I am going to just address a couple of the questions that we have. In the meantime, you will see a graphic up on your screen that just highlights all of the previous and our remaining sessions of SickleSMARTSummer. We do have a couple of questions that I want to run through really quick. I know that we are past our time, but I appreciate everyone who's able to stay. And the first question is for Dr. Rye. Where's my glasses? Because I can't see. Okay. It is what have studies shown regarding aspirin for CNS complications like moya moya, where it is equivalent to surgical intervention after 2 to 3 years?
It's a
But
great.
I'm gonna, there we go.
It's a great question, but unfortunately, I don't have a good answer because there's not enough data to support anything. Use of aspirin is basically consensus-based guidelines. So revascularization studies have shown to decrease the risk of stroke recurrence, especially if you have moya moya in the first 2 years. But there have not been enough studies to say that, you know, aspirin is alone by itself beneficial or in combination. So I think we still need more studies and more long-term follow-up to answer that question. So unfortunately, I don't have a great answer. But at our institution, we start them on aspirin, send them for a neurosurgical consult, and post-op they are on it for some time.
Excellent, excellent. Thank you very much. The second question is for Yvonne. Are you aware of any conversations around stipends or financial assistance that's available for those who would like to participate, or are there limitations related to that for clinical trials?
So it's almost a catch-22 because most IRBs will limit what you can give people to participate in trials because they don't want it to seem as if you're paying people to participate in the trials. So so some do give stipends, but usually they're not large amount of money. The longer the study goes, the more incremental money that they usually allow to be given, but it's never a large amount of money that can be given for trials.
Thank you for clarifying that. Our next question is, and by the way, I want to make it clear, we have guests that are watching all the way in Africa, and so there are a couple of questions that are more global minded, and it is for, we had a viewer that talked about a patient who had stroke, who can no longer speak. And are there post-stroke medications that aid with walking and speaking? Who wants to take that? And if there's not options, if we can just call that out as well. Dr. Rai?
Yeah, I don't think that there are any specific medications, but as I said before, that if you've had a stroke and you don't do anything, the risk of having another stroke is higher. So you want to prevent further strokes from happening. So these patients should be on transfusions. And there is a certain group of patients who will still have strokes despite having transfusions, being on transfusion therapy. So they need to go forward for transplant. So yes, you need to just do occupational therapy and all that stuff might help, but you want to prevent further damage. So do that either with transfusions and then eventually go for transplant.
Excellent. I think that's an excellent answer, and thank you for being thorough. Another question that has come to us out of Nigeria, it is that it is currently rainy season in Nigeria, which means it's a little colder than usual. With COVID-19, with COVID-19 being so prevalent right now across the globe, are there drugs currently available for people with sickle cell disease that can help them to do better during this type of season?
So I would advise that continue with hydroxyurea. So you need to make sure your disease is well controlled. So if you're on hydroxyurea, take hydroxyurea, do the usual stuff that you always do, stay warm, stay hydrated. Any other medications that can protect you from it? I don't think so. So basically from what we've seen right now is if you're at a high risk of infections, if you get the infection, it can get worse. You can have more complications. It can trigger a pain crisis. It can trigger acute chest. So you want to just protect yourself from all that. But if you're on hydroxyurea, you're on transfusions, continue with that.
Excellent answer. I'm going to add one more just as a caregiver and something that I learned by being very well trained, and that is lung health. And so if there are things that you can do to maintain or increase lung health, such as staying away from smoking or others who do smoke with secondhand smoke, but also something that my son calls the devil's toy, which is your incentive spirometer. He hates it. And when we kind of go at it over that incentive spirometer, but it's one of the best tools out there for maintaining lung health. First and foremost during a hospitalization. But I actually am kind of on a campaign to ensure that there's an incentive spirometer in every home. Because if you learn to use your incentive spirometer when you're well, you will not be like my son and argue with me when it's time to use it when you're not well. And so the incentive spirometer, it's for such a small, light device, and one that you should be getting in every hospitalization. It really does wonders in helping to fight against acute chest. And so if you can get your hands on that, if not, using something, whether it's an online tool, a YouTube video, something that really helps you to practice deep breathing. And there are some really good deep breathing exercises that help during pain and help to increase your lung capacity. So that's just my caregiver addition.
And Ray, I'll jump in there also. There are deep breathing exercises that have been shown actually to help just deep breathing in general for lung health, but has shown a little bit of help with COVID-19. When you lay on your stomach and you do deep breathing exercises, and there are several doctors out there who have been in the trenches with COVID-19, and they have found that this has been helpful for people who aren't severely ill with COVID-19, with their lung capacity.
Wow, that's fantastic. That's something that I think is very simple for all of us to do, whether you have sickle cell or not. That lung health and maintaining our lung capacity, particularly during seasons where we do know that it's rainier or it's colder. And I'll even say in the heat, that heat can cause you to have shortness of breath as well. So thank you. I think that was a very...
I'll get you the link to the video so people can actually do them correctly. But
yes,
so you can put it on your...
Fantastic, and we will definitely share that with others. And then my last two questions are for Dr. Smith. You talked about graft versus host disease. Do we know if there is a percentage of sickle cell patients that we see or that we can expect to see graft versus host disease, and how does that compare to the general population of transplantees who may get graft versus host?
Yeah, so the incidence of graft versus host really depends on what type of donor you have. And in my experience, the incidence of graft versus host disease is not higher in patients with sickle cell disease as compared to other groups. And so on average, I would say, it's a probably 20 to 30% risk that you're going to get some degree of graft versus host disease, generally on the mild side that can be easily treated.
Excellent, excellent. And then the last thing that we want to just simply call out is we know that lentiviruses, and we know that that is a huge topic of concern, not just in the sickle cell community, but in the Black community. And better understanding what it means to use a lentivirus versus some of the historical atrocities that even Yvonne spoke of, where we were not informed, or where we were continued to study to see the effects of a disease that we would, when there's a cure available. But more specifically, how do you prevent individuals from getting the virus that is used? And in this case, we talked about the HIV virus. How do we prevent that from being from being introduced into the gene with the good stuff? Right?
Yeah. So the in the lab, the bad parts of the virus are taken out. So the parts that actually cause disease are taken out. And really the part of the virus that's used is the part that allows the contents of the virus to get into the cell. And so there haven't, to my knowledge, been proven disease with these viruses after gene therapy. However, because the way we detect HIV virus in lab tests, patients who have received gene therapy will still have some of that HIV DNA in their blood. And so they will likely have false positive HIV tests, depending on the type of test that you do. So that's certainly something to be aware of as well, and something that we talk to our patients about, that there are certain ways to test for HIV which will come back positive even if you don't have the disease.
Excellent, excellent. So I just want to make sure that I thank you all for giving your time and your expertise. Today's topics are so important to the sickle cell community, whether you are a provider, whether you are a person living with sickle cell disease, or whether you are caring for a loved one who has sickle cell disease. All of these topics are critically important to living well with sickle cell disease. Most people who know me know that my motto is knowledge is power. And I appreciate, Dr. Smith, that you also called out really the importance of sometimes just having a consult with the transplant department to better understand what are your options, what are the risks, what are the benefits. Even if in that moment you or your child may not yet be ready or may not even qualify, it is important to at least have a basic understanding of what is out there as options continue to grow. So thank you. I put it in the chat, both in the Facebook live stream and here on the Zoom call. You can go to clinicaltrials.gov to learn about more clinical trial options near you and around you, and we encourage everyone to do so. Please, if you've missed any portion of this Sickle Smart Summer session, you can access it on our website at www.SickleCellMN.org. That is www.SickleCellMN.org, and we look to have that posted by Monday, the 27th. So we just have to wait for Zoom to finish what they do, and it takes a little bit, and then we'll get that posted. Also, if you have questions that follow this presentation, feel free to email us at info@SickleCellMN.org, info@SickleCellMN.org. Thank you again to all of our presenters, as well as our sponsors, the Links Foundation, Bluebird Bio, and Global Blood Therapeutics, University of Minnesota, St. Jude Children's Hospital, as well as the Sickle Cell Treatment Outcomes and Research in the Midwest, STORM, HRSA grant. We appreciate all of the organizations who are pulling together to ensure that we are improving outcomes in sickle cell disease. When we improve outcomes, we improve quality of life. I encourage everyone, be well, be safe, and continue to fight for justice where you are. Thank you so much for your time. We look forward to seeing you next month for our Sickle Smart Summer August session, and find out more on our website. Thank you very much. Have a good day. Drink up. Yes.
Ray, before we go, I just want to give a, Ray, before we go, I want to give a shout out to Dr. Rye. She's getting married soon, and in the midst of wedding preparations, she agreed to do this. So thank you.
Thank you so much, and congratulations. That's huge. So you'll get something in the mail. Thank you again, everyone. Have a great afternoon.
Take care.
Thanks.
Great presentation.
Bye-bye.
Bye-bye.